Hello everyone, and welcome to our latest edition in the Vasculitis Road to Wellness webinar series brought to you by the Vasculitis Foundation. My name is George Casey. I'm the treasurer of the Vasculitis Foundation as well as the co-principal investigator in the Vasculitis Patient Powered Research Network. We have a great presentation for you today. Before we start, I'd like to remind everyone that registration is open for the International Vasculitis Symposium being held in Jacksonville, Florida, June 19th through 21st. And you can find out more about that on the Vasculitis Foundation website at www.vasculitisfoundation.org. Another reminder, as we go through the session today and you have questions that you'd like us to potentially address at the end of the session, please take advantage of the question functionality in the GoToWebinar tool. You should see a panel on your right-hand side and you can enter your question. We'll get to as many as we can. Best advice for questions is to try to keep them fairly general and not too specific to your individual case, but we'll try to get through as many of those as we can. So joining us today, we're very excited to welcome Dr. James A. Garrity. Dr. Garrity is a longtime member of the Vasculitis Foundation Medical Consultants and Advisory Board. And is the Whitney and Betty McMillan Professor of Ophthalmology at the Mayo Medical School in Rochester, Minnesota. Dr. Garrity is going to discuss how vasculitis can affect the eyes in patients with the disease. He is the author or co-author on more than 100 publications and is a scientific reviewer for several peer-reviewed journals. And clinical practice and research interests involve vasculitis, Graves' disease, ophthalmology, and orbital diseases. So with that, I will hand it over and welcome Dr. Garrity. Dr. Garrity, can you hear me?
Yes, sir. Thank you very much, and thanks for that kind introduction. You're right. We've been associated with the Vasculitis Foundation for a long time, ever since the small meetings in Kansas City when I bet there were probably 20 or 30 people at those meetings, and now the meetings have really grown, and this webinar is another avenue for all of us to ask questions and become informed and to help all of us as we understand these diseases. But in the time allotted today, I would like to just cover how vasculitis can affect the eye. And first of all, with some overview comments, it goes without saying that correct therapy requires a correct diagnosis. And a lot of times, vasculitis, as it involves the eye, can look just like a couple other diseases. In particular, a fungal infection, a lymphoma can look like this. So my point is that when we see somebody with eye involvement, we have to consider the eye involvement in the context of the whole person, because as we all know, certain types of untreated vasculitis can be fatal. From my perspective, if I see something that's amenable to a biopsy, I will always try to arrange for a biopsy, first of all, to establish if it's inflammatory, infectious like fungus, or even cancerous like a lymphoma. And it's important because the therapy of a vasculitis often involves immunosuppression, which of course is life-saving, but can also be associated with its own set of problems. This is a nice picture showing the various sizes of the arteries and veins. And as we have all come to appreciate, there are certain types of vasculitis that affect certain size arteries or certain size veins. And this is just an overview slide to help you conceptualize the vasculitis involvement. What we're going to do is we'll consider one type of a large vessel vasculitis, namely the giant cell arteritis. I won't mention any of the medium vessel vasculitis, but we'll spend a little bit more time with the small vessel vasculitis, the granulomatosis with polyangiitis, or the Wegeners as we all knew it before. We'll spend a little time on Behcet's, a slide or two on Cogan's, and then some rheumatoid arthritis. I've got a drawing of the eye here. And the eye manifestations of vasculitis, it can affect any of these structures. And with this little pointer, here's the eyelid, here's the conjunctiva. So when someone speaks of a red eye or a pink eye, it's often a conjunctivitis. The next layer down are the episcleral tissues, which is located right underneath the conjunctiva and right on top of the sclera. So later on in the presentation, we're going to talk about episcleritis, scleritis, keratitis, along with the orbital pseudotumors. But this is just a nice diagram to show where these various structures are located. Giant cell arteritis has been around a long, long time. And there are historical references that go back to about 1000 AD, where writings from the Middle East have described patients who, in retrospect, probably had giant cell arteritis. The first modern cases were described in 1932. Horton was at the Mayo Clinic, so the giant cell arteritis story has a pretty strong Mayo connection. In 1937, there was the first description of visual loss in the medical literature, and cortisone was actually discovered at Mayo Clinic, and in fact Mayo has one Nobel Prize, and it was for the discovery of cortisone. But the first use of steroids for giant cell arteritis was recorded back in 1949. Giant cell arteritis has some very nonspecific presentation signs. Headaches. If you take your fingers and feel the muscle that you use to chew over the temple of your head, that's typically where a lot of the headaches are located with giant cell arteritis. Amaurosis fugax literally means fleeting blindness, and many times patients who have giant cell arteritis will come in and give us a history where they've temporarily gone blind for 3 to 5 minutes perhaps, and other patients might come in and give us a history of double vision. And all of these symptoms reflect involvement of the vasculitis. Objectively, when we look at the eye, many times we can see evidence of an ischemic optic neuropathy. What an ischemic optic neuropathy is, it's a stroke. It's a stroke of the optic nerve. And I'm going to show you a picture of that in just a moment. When we see somebody with an ischemic optic neuropathy, our biggest challenge is to figure out if it's the arteritic variety or if it's the non-arteritic variety. The non-arteritic variety is actually much more common, and it typically would affect patients in their 60s, and the involvement tends not to be as severe as the arteritic variety. The arteritic variety is typically in their 70s and 80s and usually involves much more extensive vision loss. The reason we would like to distinguish the two is because with the arteritic involvement, the eye is at risk. The other eye is at risk. So when an eye is involved with a vasculitic ischemic optic neuropathy, the whole point of therapy is not to get back vision that's been lost in the involved eye, but rather it's to save the other eye. The other way giant cell arteritis can show up in the eye is to have a stroke that involves the retina, and it's called a central retinal artery occlusion. And they're typically thrombotic, which means that the blood vessel just kind of closes or becomes narrow to the point where blood does not flow through it. The embolic variety would not be expected to occur with a vasculitis. An embolus is actually a little fragment of a clot or something along that line. So here we see a picture of an eye. This is actually a left eye. And right dead center in the picture is the optic nerve. And you see all the blood vessels coming out from the optic nerve. And then you also see little hemorrhages alongside it. And the edges of the optic nerve are blurred. So that's a swollen optic nerve. And this is what an ischemic optic neuropathy would look like. The vision would typically be extremely poor. The pupil wouldn't work well. And the patient would have a visual field defect, which means that portions of the visual field would be missing. Typically, it would be either a top half or a bottom half of the vision. So this is the appearance of an ischemic optic neuropathy. Here is an appearance of a central retinal artery occlusion. And what you see right dead center is the macula. And then all the white area around it is the retina. And it appears white because it's swollen. And it's swollen because it just sustained a stroke. So an ischemic optic neuropathy or a central retinal artery occlusion would be two of the common eye findings that we would see with giant cell arteritis. In terms of diagnosis and therapy, the first thing is to suspect the diagnosis. As I mentioned, most of the people who have ischemic optic neuropathy or giant cell arteritis tend to be in their 60s, 70s, and 80s. They typically have a headache. One finding that's fairly common, or specific, I should say, for giant cell arteritis is jaw claudication. For example, if you went to a restaurant and got a piece of a tough steak and you chewed on it, the muscles that you use to chew would get sore, and you'd notice headaches after you've chewed for a while, and that's what jaw claudication is. And we mentioned the transient visual loss, the amaurosis, or the fleeting blindness, and the double vision. If you came into the emergency room with any of these symptoms, we would do a blood test, which would measure your SED rate, your complete blood count, and the C-reactive protein. And one would expect them to be quite elevated, the SED rate and the CRP. And also the platelets might be elevated on the CBC. So combined with that history and these lab test results, we would suggest going ahead with a temporal artery biopsy, which is an outpatient surgical procedure that's just done with some Novocaine or lidocaine in the office or the surgery center. The therapy usually starts out with steroids. If someone has lost vision acutely and one thinks that the other eye is imminently in danger, one could even give intravenous steroids, which would give a much larger dose, much more rapidly than the oral steroids. And people are on steroids for a long time with this disease. One could also consider adding some aspirin as a blood thinner. In terms of the prognosis, there was a paper published in the medical literature about 10 years ago that prospectively looked at about 34 patients, and they followed them for an average of 5 months. If there was vision loss, they gave them intravenous steroids for 3 days, followed by a course of oral steroids. And interestingly, 11 of those 40 eyes, or 27%, had progressive vision loss despite this. Most lost their vision in about 2.5 days, but in some of them, it persisted for up to 6 days. 3 eyes that were initially normal became involved even after the intravenous methylprednisolone or the intravenous steroids. And all three of them lost vision within 1 day of the steroids. And as you can see, a dose of 1 gram of intravenous methylprednisolone is a huge dose. So that's the only prospective study, so you can see why when we suspect this diagnosis, we want to get somebody on therapy right away. In terms of spontaneous improvement, only about 5% improved either the visual acuity or the side vision. And as you can see from the slide, it was about a month to get the improvement. The paper concluded by saying that the greatest risk of vision loss is in the first 6 days. When one performs a temporal artery biopsy, you want to get a representative segment. And what that means is that you want to get at least 1.5 inches or 3 centimeters on the biopsy. Sometimes you can have patchy involvement. You know, skip lesions are what it's called. So that's why you want to make sure that you get a representative length of the temporal artery. You'd like to do the biopsy within 2 to 3 weeks of starting the intravenous steroid or the steroids. And the reason for that is that these steroids are a very strong anti-inflammatory medication. And if you take the steroids for longer than 3 weeks and you do the temporal artery biopsy, you might not see any evidence of the inflammation in the biopsy specimen. So once you start steroids, you'd like to get the biopsy within 2 to 3 weeks. One of the reasons for doing the biopsy is to justify all of the side effects. As we all know, steroids are a wonderful drug, but they've got a whole host of side effects. And for that reason, we want to be darn sure that we have the right diagnosis in order to persist with the steroids. Now, here's our anatomy again. And what I wanted to show one more time is here's the conjunctiva for the conjunctivitis. Here are the episcleral tissues for an episcleritis. And here's the sclera, or the wall of the eye, for a scleritis. And let's first consider scleritis. When one has a diagnosis of scleritis, this is a sight-threatening eye condition. It can lead to glaucoma. It can cause a cataract. It can cause swelling of the back of the eye. And untreated severe scleritis can actually perforate the globe. Scleritis is also associated with severe pain. And just an anecdotal story, the very first patient I ever saw in the training program here at Mayo was a gentleman who came up to our front desk requesting that his eye be removed because of the severe pain. And as it turned out, he had a severe scleritis that was eventually found to be secondary to GPA. And of course, all his pain went away once he was treated, but that's usually the level of pain that someone with scleritis might have. It's associated with active disease, so if we see someone who's had stable GPA and all of a sudden they come in with a scleritis, that tells me that their GPA is not adequately controlled, and it implies active disease. Sometimes you see patients who have a scleritis that just come in with eye drops. Eye drops aren't strong enough to take care of a scleritis, and one usually needs prednisone pills, Cytoxan, or Rituxan. When the scleritis heals, it leaves a little blue spot on the eye, and I'll show you what that looks like in just a moment. So here's some more anatomy, and I've got my pointer now on the sclera, which is where this big black arrow is. And with a scleritis, you've got inflammation within that layer. And here are the episcleral tissues where I've got my pointer on now. And here's the conjunctiva, this darker layer here. So scleritis involves inflammation of the wall of the eye. Yeah, let's see. There we go. And so once again, here's the involvement of the sclera. And here is a slit lamp examination. That's one of our instruments in the office, but it shows a little nodule in the wall of the sclera. There are different types of scleritis, and the implications of each type we will discuss momentarily. Anterior scleritis is the most common. And here is the diffuse and nodular, which makes up about half. The necrotizing makes up about 70 to 95% of them. And the necrotizing is usually painful. If there's no pain with the necrotizing scleritis, that's called scleromalacia perforans, and that's typically seen in rheumatoid arthritis. The posterior scleritis has about a 29% risk of systemic disease. I'm sorry, let me back up a little bit. The necrotizing scleritis has about a 70 to 95% chance that it's going to be associated with a systemic disease. The diffuse and the nodular has about a 40% chance that it's going to be associated with a systemic disease. And the posterior has a 29% chance that it will be associated with systemic disease. Another paper in the journal Ophthalmology in the year 2004 had a chance to review 243 patients who had scleritis. And the median age was about 52 years, with a range that went from children to elderly adults. They followed this group for almost 2 years, and they found an associated medical condition in almost half of them. One of the infectious causes of a scleritis is shingles. Herpes zoster ophthalmicus it's called. The others had some type of a rheumatic condition, and it was typically either rheumatoid arthritis or GPA. If there was an associated medical condition that was diagnosed, it had been previously diagnosed in about 3/4 of them, and 14% of them, the scleritis was actually the presenting sign of a new medical diagnosis. And 8% developed the medical disease during the follow-up. Here's a diffuse scleritis. And as you can see, the eye is just quite red, and it's a white cornea from corneal edema. And there would be a significant amount of pain associated with this. Here's a necrotizing scleritis. This would be exquisitely painful. And this little nodule here, you can see that the inflammation is also spilling over onto the cornea. So this is called a keratitis. So it's a necrotizing scleritis with a necrotizing keratitis. This would be extremely painful. And here's what a healed scleritis looks like. It's a little blue patch on the sclera, or the white part of the eye. It's been thinned, so you can actually see the dark color of the inside of the eye through that. But that's what healed scleritis looks like. Rheumatoid arthritis affects about 1% of the general population. Of all the patients who have rheumatoid arthritis, less than 1% get a vasculitis. That's important because a vasculitis in association with rheumatoid arthritis is associated with increased mortality. And in that setting, stronger doses of immunosuppression or even drugs like Remicade are easily justified in that setting. In terms of the ocular manifestations of rheumatoid arthritis, about 13% will have a Sjogren's, or real bad dry eye, dry mouth. 1 to 6% have a scleritis, and rarely the vasculitis can cause a corneal melt, which can lead to a perforation of the eye. And here are some eyes with previous rheumatoid arthritis. And here's the scleromalacia perforans, is what it's called. It's actually a necrotizing type of scleritis, but there's not much in the way of pain with this, and there's not much in the way of inflammation if you looked at that under a microscope. Here's an area of scleromalacia perforans that has a scleral patch graft sewn in place over it because it was so thin that it looked like the eye was going to perforate. And here's some inflammation that's spilled over onto the cornea. This is a keratitis. And this is taken at a slit lamp. So you see the beam of the slit lamp, and all of a sudden it gets cloudy right here. So this area, this whole superior area of the cornea is involved with the keratitis. Now some time with GPA or the Wegeners granulomatosis. Dr. Abdu, back in 2002, surveyed the entire group of the Wegeners granulomatosis support group. And from that, he generated these numbers. 68% presented with sinus disease, 62% presented with lung disease, about half showed up with nose involvement, 43% with ear involvement, and here 30% of people who ultimately had Wegeners showed up with eye involvement as their first indication. Then during the course of follow-up, 33% eventually had eye involvement, and as you can see, the other numbers, 30% joint, 30% kidney, 22% sinus involvement. So the take-home message from this was that about a third of the people will have eye involvement at presentation. We had a chance to look at some of the Wegeners patients here at Mayo back in 1983. And out of a group of 140 patients with Wegeners or GPA, 40 of them had eye involvement, so about a third. And this fits nicely with the survey results that Dr. Abdu had. In terms of what was the eye involvement, 45% had involvement of the eye socket or the orbit, and I'll show you exactly what I mean by that in just a moment. 38% had involvement of the sclera or episcleral tissues. 28% had involvement of the cornea. And now you get down into some of these unusual features, like 22% had optic nerve involvement, 18% had retina, and 10% had a uveitis. The take-home message from this slide is that it's usually the eye socket or the orbit, the sclera, or the cornea that become involved with GPA. So 45% had orbital inflammation, 33% with scleritis. Whenever we see somebody who has orbital pseudotumor is one of the terms that's used to describe orbital inflammation. But if we see somebody who has orbital inflammation or has scleritis or recurrent episcleritis, we'll send off a blood test, the ANCA test. And many times the ANCA test is positive, which will help us with the diagnosis. From my perspective, I think an orbital biopsy is imperative to establish the diagnosis of GPA. And the reason for doing that is because all these conditions listed here, the lymphoma, fungal disease, metastatic cancer, sarcoid, or a foreign body, all these diseases can look exactly the same as Wegeners or GPA on the CT scan. Here is a CT scan of someone with severe GPA. And what I want you to look at, number one, look at these sinuses. They're clear. And I think it's a little bit easier when you see eye socket involvement with sinus involvement, because there are just a few things that do that. Notably, GPA is one of the most common. But the eye socket should be black, like this. This is normal orbital fat. And this cloudy area represents involvement of the orbital tissues by Wegeners, or the GPA. So it completely surrounds the eyeball and extends back inside the skull. This is the area called the cavernous sinus. So this inflammation is not only in the eye socket, but it's also intracranially. Here's what that biopsy specimen would show. And what you see here is these are all blood vessels. This is what vasculitis looks like underneath the pathologist's slide. And in addition, there are a whole bunch of inflammatory cells that you see here. But the notable feature is the involvement of the blood vessels, or the vasculitis. Here's a gentleman who a couple years ago was being maintained on methotrexate for his generalized GPA, but despite the methotrexate, his eye became progressively protruding, and you can see the redness of the eye. There was so much involvement by the scar tissue, or the orbital pseudotumor, that it caused his optic nerve to swell. As here you can see the edges are a little bit fuzzy, and compare that to the optic nerve on his other side. So this eye was in trouble because of all the fibrous tissue that the Wegeners had produced. Here's what his eye looked like afterwards. Now remember, with the scleritis, I had mentioned that one cause of scleritis is shingles. This is probably the worst case of shingles that I've ever seen, but it produces necrotizing or trouble with the skin, and all this black area is almost gangrenous skin, and here you see the scleritis. But the herpes zoster ophthalmicus, or shingles, can actually cause a vasculitis in its own right. And here you see an old angiogram, and what it shows is, here's the carotid artery, and when the carotid artery goes intracranially, or through the dura, it causes a vasculitis. So here you see the caliber of this artery changes, reflecting the vasculitic involvement, and the shingles actually caused a stroke. Let's consider some episcleritis now. Episcleritis can have no symptoms, and from my own personal experience, a couple years ago I had people coming up to me and asking me about my red eye, which I didn't know I had, but it's typically sector-shaped, and if you put in a drop of neosynephrine, it will completely make the redness go away, and that can be one of the diagnostic signs of an episcleritis. The vision typically is normal and minimal to no pain. There's no mattering that you might have with a conjunctivitis. And episcleritis can also be associated with active disease. So anybody, typically with GPA or Wegeners, who shows up with an episcleritis, I'm a little bit concerned that it could represent active disease, and we will investigate accordingly. About 30% of people who have an episcleritis will have some sort of a systemic disease association. And this one, as opposed to the scleritis, you can treat with an anti-inflammatory drop. So scleritis, remember, that usually needs pills or something intravenously. The episcleritis, you can treat that with inflammatory drops. And many times, after you treat the episcleritis, it might come back. So here's the anatomy of an episcleritis. So here's the sclera again, and note that that's normal. Here are the episcleral tissues where all this inflammation is concentrated. And then here's the conjunctiva, or which you'd expect to be involved with a conjunctivitis or a pink eye. So here are the normal episcleral tissues. Here's what episcleritis looks like in a cross-section. And here's what the episcleritis would look like if you use your slit lamp in our office. And notice that the leading edge of the beam goes over that nodule, but the trailing edge of the beam is perfectly flat, which reflects this right here. And remember, in a scleritis, both edges of the beam would go over that nodule. Here's a typical appearance of an episcleritis. And notice that that looks sector-shaped. And it doesn't look as red and angry as the scleritis did. Now to move on to Behcet's. Behcet's is often associated with oral ulcers, which, or canker sores, kind of like that, which can be very painful. There can also be genital ulcers, and from the eye standpoint, we see this hypopian uveitis. A hypopian is a collection of white blood cells in the anterior chamber of the eye, and I'll show you a picture of that in just a moment. This anterior uveitis, uvea is the Greek word for grape. And if you take away the sclera, what remains is this uveal tissue. And a uveitis is just a nonspecific term that implies inflammation of the structures inside the eye. The anterior uveitis is the most frequent eye manifestation. And a retinal vasculitis affects both the artery and the vein. Prior to treatment, the majority lost vision over a 5-year period of time, and the diagnosis of Behcet's usually means that you'll be immunosuppressed. Now here's the inside of the eye, and if you took away the sclera, you'd see the iris, the ciliary body, and that's what makes up an anterior uveitis. If you'd have an iritis or a pars planitis might be one of the terms that you would hear. The posterior uveitis would involve the choroid and the retina. Here's a typical hypopian uveitis from a Behcet's. And what I would like you to see is, look at this eye. It's as white as a cue ball. And in addition to the eye appearing white and quiet, look at the white material that's layered out at the bottom of the eye. This is called a hypopian. There are so many white blood cells circulating in the front part of the eye that they've layered out. So this is a hypopian uveitis, and this one would be classic for a Behcet's. The funny-looking pupil is because there's so much inflammation that the pupil has stuck down to the leading to the front capsule of the lens. So that's why this pupil looks so funny. And here's what the back of the eye looks like with Behcet's. And there's some sheathing around a vein. So here's involvement of a vein. Here's involvement of an artery. So Behcet's typically involves both. The clinical findings, at least the eye disease, the greatest cause of morbidity in a patient with Behcet's is the vision. And it's a relapsing uveitis, anterior, intermediate, and posterior, a panuveitis. You can get a vasculitis involving the retinal blood vessels, and it will actually occlude or plug the vessel. And it eventuates with a severe loss of vision if it's not treated. The eye disease affects 60 to 90% of patients. Limited anterior segment involvement is uncommon, like 6 to 15%. And that classic hypopian that we saw was also fairly uncommon in 6 to 30% of patients. But when you see it, it really can't be much else other than Behcet's. Both sides, right and left sides, typically is the rule. and loss of vision is unfortunately common. The anterior segment findings include inflammatory cells, which we talked about, you know, the hypopyon. The keratic precipitates are little clusters of inflammatory cells that stick to the back of the cornea. The posterior synechia, I showed you where the iris was stuck to the lens, and then you can get a cataract. Glaucoma is fairly common because of the recurrent nature of the inflammation, and it literally plugs the drain. So then the pressure goes up. The findings in the back of the eye include inflammation in the vitreous, which is the jelly in the middle of the eye. You can get hemorrhages on the retina. And then where those blood vessels get occluded, it can cause a stroke or an infarction of the retina. So venous and arterial occlusions. And you can also get some swelling at the back of the eye called the macula. Other clinical findings, you can get enough inflammation in the vitreous to cause the optic nerve to swell. When the optic nerve has been damaged, it turns color, it becomes pale, we call it. And then pigment epithelial changes on the retina, which reflect vasculitic involvement. Male patients, as a rule, have a worse prognosis in Behcet's. And when we see somebody with red eye and suspected Behcet's, if there's the cold hypopyon, you know, the white, quiet eye with a hypopyon, that almost as always is Behcet's. If you see the white blood cells layered out and the eye is red, angry, painful, swollen, it's usually not Behcet's, but it could be a masquerade condition, like leukemia can do that. And there are certain types of other rheumatic diseases that are associated with HLA-B27. So here's the cold hypopyon that we talked about. Notice that the eye around the edge looks pretty quiet, and then there's the hypopyon. And that's to set it apart from the red angry one. So other connective tissue diseases rarely affect both the arteries and the veins. And many times the eye disease is the first manifestation of Behcet's. And in terms of, well, what else could it be? Certain viral infections, especially those associated with retinal necrosis, can be confused with Behcet's. That's why the history is so important. You know, have you had ulcers in your mouth? Have you had ulcers on your genitals? Because a viral retinitis wouldn't typically do that. And many times the person taking care of the patient will have to do what's called a tap, where you stick a little needle in the front part of the eye to get out some of the fluid to do diagnostic tests to look for the virus. It's called a PCR. So let me summarize. I know we went through a lot of things very quickly, but let me summarize by saying that if you show up with eye involvement, the clinician has to think of many, many other things other than the vasculitis. From my standpoint, it's essential to prove with pathology whenever we can, just because there are so many other mimicking conditions, and the treatment of those other conditions is so vastly different. And when we see someone with eye involvement, is it just isolated eye involvement, or is there involvement of the lungs, the skin, the joints, or what else is going on? And what we need to do is interact with other specialties, rheumatologists, pulmonary specialists, to discuss the specifics of each individual case. And I think that any diagnosis of vasculitis is a justification for fairly aggressive treatment, since the downside is so significant. But that pretty much summarizes everything that I wanted to cover with the vasculitis. And I think George and Kaylin, we have time for questions, don't we?
Yes, we sure do. Thank you, Dr. Garrity. So we've had a couple of our patients submit some questions during the presentation and also prior to your presentation. One of them was, I would like to know if macular degeneration is linked to vasculitis or the meds that we take to treat vasculitis.
Let me give you kind of a long answer to a short question. The macula is the portion of the retina that we use for our high-definition vision. So that's the reading, the writing, the recognizing faces. So that's the high-definition portion of the retina. And when that degenerates, that causes us to lose our visual acuity, our straight-ahead vision. But our side vision is always there. So, for example, if you looked at my nose and you had macular degeneration, you would see the top of my head, you'd see the bottom of my chin, you'd see each ear, but you would not see my face in the middle. Your side vision would always be there. It's just your central vision that's gone. I cannot think of any specific type of vasculitis that is associated with macular degeneration. On the other hand, I can't think of any specific medication that would lead to macular degeneration in the setting of vasculitis. So from my perspective, I think you'd have to say that macular degeneration in the setting of vasculitis would be coincidental.
Okay, great. Thank you. Another one of our questions that came up during the presentation is how often should a GPA Wegener's patient who is in remission have their eyes checked?
I think that they should get their eyes checked anytime there's a question. For example, if the Wegener's was stable or GPA was stable and now all of a sudden you have a red eye, I think that would be worth a check. We could have a whole separate talk on red eye, but there are many causes for a red eye. And it could be as simple as something called a subconjunctival hemorrhage, which we see a lot in people that take prednisone, that take aspirin, that are on Coumadin. And if they cough, sneeze, rub their eye, that wouldn't be a cause for concern, but certainly if someone would have a red eye associated with pain or loss of vision, the presence of double vision, I'm trying to be pretty non-specific with these recommendations, but I think that if you're concerned and you have a disease like Wegener's, which has a known association with eye problems, I'd get it checked. We've also, many of our patients come from a long distance away, and if they have a red eye, I just ask them to send me a picture, and many times you can tell with the picture if it's something as simple as a subconjunctival hemorrhage or if it needs more evaluation. So the quick answer is if you're concerned, I'd get it checked.
Great, thank you. And kind of in accordance with that, we had another question that was, can steroids affect vision? So like taking prednisone, can that affect one's vision?
Yeah, here's another long answer to a short question. Prednisone comes in a couple different forms. You can get prednisone pills. You can also take it intravenously, or you can also take it as a drop. Let's do the eye drop first. If you use prednisone drops, it's called prednisolone forte or pred forte or prednisolone acetate. Those are some of the names. But prednisone drops, if you use that for a long period, it can cause problems in and of itself. It makes you a little bit more susceptible to certain types of infections, namely a viral infection, namely herpes simplex. So that's one thing. It makes you more susceptible to certain infections. The other thing is that it can cause glaucoma. It's called a steroid responder, if you ever hear that term, if you go into the eye doctor's office. So steroid drops can cause glaucoma, and steroid drops can also cause a cataract. So if you're using those drops, I think you just want to make sure you're under somebody's care who can follow that. Prednisone pills is basically the same thing. It can predispose you somewhat to glaucoma, probably not as much as using the steroid drops. It can also cause a cataract, and one of the old rules that I remember is that if you take 10 milligrams of prednisone daily for a year, your chances of cataract will be pretty high. But you know, if you need the prednisone, you should take it, because if you do get a cataract is eminently treatable with cataract surgery. You can also get prednisone or cortisone by the vein, but usually folks don't take enough for long enough to get into eye problems with that. So it's the prednisone pills and the prednisone drops that I think you should be most cognizant of.
Great, thank you for that.
Get the question? Yeah. Okay, good.
And the detail was great. So another one of our questions was, what treatment of a TNF inhibitor is known to be the least harsh on your body?
That is a tough question to answer because the TNF inhibitors, there's a whole bunch of different types of TNF inhibitors, and you know, you can, like Humira, Enbrel, Remicade, and the Remicade is intravenous, and the other two are subcutaneous. That might depend, because some people like the intravenous because it's given like once every 2 months or so. The Enbrel is just a little shot you can do at home once a week, and the Humira is a shot at home once every couple weeks. So I'm not trying to dodge the question, but I think that's a hard question to answer because it depends.
Sure, no, that's a good answer. So one of our other questions was, can the eyes recover from damage done to them by vasculitis once treatment is started and takes effect?
It would depend a little bit on what the damage was. Let's say that the vasculitis caused one of the blood vessels inside the eye to become plugged, physiologically plugged, so that it would produce a stroke. And the condition I'm thinking of would be the ischemic optic neuropathy. And if it's the arteritic variety of ischemic optic neuropathy, one would not expect the vision to improve very much. So usually when that happens, the damage is done. And the whole point in therapy is to prevent the same thing from happening to the good eye. So as a general rule, once the damage has been done from a vasculitis, it's not going to recover. Now sometimes when we see vasculitic involvement in the orbit or the eye socket, that might get better with the Rituxan or Remicade or something along that line. We have also done surgery to debulk some of the scar tissue from behind the eyes, and folks have done well with that surgery. But in general, though, once you've had damage from a vasculitis, it's hard to get it to improve on its own.
So, Dr.
Thank you so much.
George, I'd like to jump in with one last question. I think we have time for one more question. I think we had some people asking, since it's hard to address all the different vasculitides, but understanding, we talked a little bit about Behcet's and GCA and GPA, but for people with MPA or microscopic polyangiitis, how would they interpret this message? Is this generally kind of the same information for them, or are there any specific things that they would look for differently?
Yeah, the folks with microscopic, I think by and large would follow the GPA, because I've seen quite a few people with the microscopic, and they show up with the same symptoms, the same findings as the Wegeners or the GPA patients. So the microscopics would behave like that.
So I think that's a great answer and a great place for us to wrap up the presentation today. I would like to once again thank Dr. Garrity for sharing his time with us and his expertise. I would offer to the rest of patients that this is the type of information and access you can get by attending the symposium in Jacksonville. We'd love to see you there and have ability to kind of dive deeper into your particular or specific questions. And once again, we'll make a plug for our vasculitis patient-powered research network, which you can access at www.vpprn.org. So thank you for attending this